Welcome to Spine Academy. In this video, we're going to provide an overview of the different surgical techniques that we use for the anterior approach to the cervical spine. We'll start by providing an overview of the anterior approach. So therein, we'll talk about the anterior exposure corridor, we'll talk about some of the common indications for surgery from the front, and then we'll talk about a summary or provide a summary of the different characteristics for the anterior approach. We'll then switch gears and go into specific surgical procedures, and we'll start with the most common procedure, which is an anterior cervical discectomy and fusion. Now, this is a workhorse procedure that is an incredibly powerful and popular surgical procedure, so we'll provide a description of the procedure and then provide a summary of the characteristics of that procedure. We'll switch gears then and talk a little bit about the anterior cervical disc replacement, which is a procedure that is growing in popularity and relevance. And we'll again provide a description of the procedure with an animation and also a summary of those characteristics, especially relative to the ACDF. Lastly, we'll talk about an anterior cervical corpectomy and fusion. Now, this is a procedure that is very powerful, but certainly not quite as common, but I still present it because it is useful in select scenarios. And so I'll provide, once again, a description of that procedure and a summary of the characteristics and when it is useful. I hope you find this useful and look forward to seeing you in the sections to come. There are many different surgeries that we do from an anterior approach, but let's talk about the exposure and the approach generically. If you look at the spine from the side, you can kind of see here with the skull in place that here's the spine. This person has a fair amount of pathology at these levels with some instability and even some kyphosis. But you can see kind of with the frame around it that the front part of the spine represents everything from here, and that is what we consider anterior approaches, approaches from the front of the neck, which would be kind of here on me. Approaches from the back are approaches from the back of the neck, obviously. Now, if you were to take a slice of the neck like this, it would look a little bit like this. So here you could see the spine itself, you could see the spinal cord and some of the nerves on either side, and you see the structures that it sits within. So here you can see some of the muscular stuff in the back, but we're going to talk first about the anterior approach. So the anterior to the spine, or in front of the spine, which is this direction here, you can see that there are some important structures. There's the esophagus, the trachea, which kind of mediates swallowing. The esophagus carries food from your mouth down to your stomach, and of course your trachea helps with both breathing and also with phonation, which is like voice and so forth. Those structures sit immediately in front of the spine. Now, you do have some big blood vessels that are off on the side here. When we refer to anterior approaches, we're talking about approaches that come from here. So let's talk about what structures you can see well with that. Here you can kind of see if you came in from the front, and not through these structures, but from the front, you would have access to these structures. You'd have access to the disc, to the front of the spine with the nerve on one side, the nerve on the other, so you can access both sides. And you could also see the spinal cord here. You can access structures that are in front of the spinal cord. So the anterior approach is an approach from the front of the neck that allows you to target or address pathology that is in front or anterior to the spinal cord and the spinal nerves. That is generally what an anterior approach is. Now, obviously, we don't go through those structures, so the way that this is done is that we generally make an incision. I mostly make incisions that are horizontal. They go in a skin crease of the neck. And then you can dissect some very superficial structures, and there's a very natural plane that gets you to the front of the spine. So again, you can access the disc, the spinal cord, the nerves, you can access structures in the front, but you go between some structures and you move the esophagus and the trachea and stuff to one side. I generally make a left-sided incision, so this should be on the left, and these structures would be pushed off to the right. And even if it looks quite extreme here, you're only really pushing it about a centimeter to the side. You're kind of creating a boundary here or a fence to protect some of these structures. You really don't have to move them a whole lot. And that is the exposure that we use to get to the front of the spine, regardless of the specific surgical technique that we're doing. So now, if you imagine looking at, again, the pathology, we don't go through this, but it allows us to address pathology here. So typical indications for which we do anterior approaches are when people have pathology in the front of the spine. So if you look at a sagittal slice, here you can see a very simple situation where somebody has a disc herniation between C5 and C6. This is causing some pressure on the spinal cord. If you were to take a slice of it like this, you might see a picture that looks like this. And here you can see this disc herniation pushing on the spinal cord and pushing on the spinal nerve on one side. This is a situation where somebody has a disc herniation and has pressure on the spinal cord and pressure on the spinal nerve, and that is a very common situation which we would address from the front. Now, because we're going in from the front, the pathology doesn't always have to be way off on one side. It can even be right in front of the spinal cord. And when you're coming in from the front, you can access this directly, because again, we're coming right down the center. This is easy to remove. You can also have pathology at a few levels. It doesn't have to be at one level. And so if you look at a slightly different sagittal slice, here you can see this person has pathology at 3 different levels. The pathology is mostly in front of the spinal cord, so it kind of makes sense to address this from the front if permissible. It's all pressing on the spinal cord, and you can access multiple levels. Most of the time when I'm doing anterior approaches, it's really ideal for 1 or 2 levels, sometimes 3 levels. I'd say the lion's share of when I do it is for 1 or 2 levels, but 3 is certainly permissible, and you can do more than that, although I think that's a little bit more uncommon. You can see when you go in from the front, you cannot access pathology that is behind the spinal cord, right? If you come in from here, you can't go through the spinal cord to get to that. And similarly, when you come in from the back, you can't get pathology at the disc level from the back. So understanding where the pathology is, and we use MRI and CAT scan and x-rays to do that, helps a lot with trying to pick the right trajectory. Now, there are other things besides disc herniations where an anterior approach can be super valuable. Here's an example of somebody who has some disc degeneration. Here you can see there's like very little disc left between C5 and 6 and between 6 and 7. So this is the C5-6 disc. It's got a lot of degenerative disc disease, a lot of disc height loss. You can see that that's true at C6-7 as well. A lot of times when people have pathology like this, they have a lot of bone spurs, and if you took an axial slice here, you might see something that looks like this, where you have all these bone spurs kind of helping compress the nerve here. You can see there's some bone spurs in the back as well. And this is an important illustration because if you picked an approach from the front, you could get the pathology from the front. Maybe there's a herniation on the other side or something. You could remove the bone spurs here. You can remove the pathology that is in front of or anterior to the nerve and the spinal cord. You cannot get to the pathology that is behind it. So in a situation like this, you would very readily, I think, be able to address part of it and free up the nerve enough to create enough room. And that would be sufficient from a foraminal decompression perspective. The other thing you can do when you go in from the front, and we'll see this more when we talk about specific procedures, is when you go in and remove this disc, you can distract it, you can jack it open, you can kind of increase the height of it and put a spacer in there to kind of occupy that space. And in doing so, you can restore height and you can restore alignment. So a situation like this is ideally addressed from the front if you're trying to help correct alignment. So in summary, anterior cervical approaches are approaches from the front of the neck. They can address pathology that is in front of the spinal cord and the spinal nerves. It's ideal really for 1 to 3 levels, although more can be done. I would say the lion's share of surgeons and the lion's share of anterior approaches are ideal for 1 to 3 levels. Usually the levels in question are between C3 and C7 because it's very hard to get very high and very hard to get low. It can address pathology on one or both sides. So it can address bilateral pathology because it's a midline procedure. Even if the incision's off to one side, you get right to the middle and expose the full width of the spinal canal, and that allows you to decompress right, left, or both. It's great for alignment and disc height restoration because, as I showed in that one illustration, you can take out whatever disc is there and distract that space open and restore height to that level, which is great for disc height restoration. It's great to restore volume of the foramen that the nerve is coming out of, and it's great to restore alignment. When you go in from the front, because you're moving some of those structures to the side, even if it's only moving it 1 centimeter to the side, because you're moving it to the side, often people will have some degree of swallowing and hoarseness issues. And I tell people more or less to expect it for a couple of days after surgery, but sometimes people can have permanent disruption of their swallowing function and their voice. Generally, surgeries from the front are a little bit better tolerated in younger patients because they often don't have a lot of pre-existing voice problems and swallowing trouble, and their tissues tend to be a little bit healthier and their esophagus tends to tolerate that a little bit better. Surgeries from the front have a very low rate of infection, and it has to do with the way your body is made. There's not a lot of dead space. When we do these surgeries, we're usually dissecting between structures, and you can very freely kind of mobilize those structures, almost like you're looking in a window, creating a little space, doing your surgery, and then on the way out, everything kind of closes up to kind of close that space back down again. So for a variety of reasons, infections from the front are incredibly uncommon. For all of these reasons, surgeries from the front are a real workhorse procedure and a really valuable approach to the cervical spine that your surgeon may find relevant for you. Having said that, there are different types of surgeries, and we're going to talk about them specifically next. The anterior cervical discectomy and fusion is an incredibly powerful surgical technique that we use to address pathologies generally in the front of the spine. So let's start with an illustration to kind of give you a sense of what the procedure itself involves. If you look at this animation here, you can see that this is the front of the spine here. If you imagine that there's 3 levels of degeneration at these discs, for example, it might look something like this, where there's a disc herniation and some bone spurs. When we do an ACDF, we're removing the disc material on both sides. All of the disc material really is being removed. We remove the herniations pressing on the nerves and some of the bone spurs that are pressing on the spinal nerves and the spinal cord. And this creates a gap that we usually fill with a spacer. So we might use a trial like that to pick the right type and size of spacer and use it to fill that defect between these 2 blocks. We'll usually secure those blocks with a plate, and the plate is designed to secure them or glue those levels together. Usually we'll use screws to hold the plate to the vertebral bodies, and in this case you can see between C5 and 6 that this plate is being used to secure 5 and 6 together. Now, an ACDF can be done at 1 or more levels, and here you can see if you took out the disc and put a spacer at the level above, the plate would be a little bit longer, and this time you would use 6 screws to secure the plate to these 3 vertebral bodies to fuse across these 2 discs. So an ACDF is generally done from the front and can secure 2 or 3 or more levels as needed. It would look a bit like this, and at the completion of the procedure, these levels would not move anymore. So as people move their neck afterwards, you can see that the other levels are really the levels that are going to pick up the bulk of the load. That is one of the traits of an anterior cervical decompression and fusion. So now let's talk a little bit about the clinical situations in which we might use an ACDF. So if you look at a slice like this, an axial section, as you may be familiar with here you can see that this person has a disc herniation with pressure on the spinal cord here, a little bit of pressure on part of the nerve rootlets over here going out here, but no real formal pressure on the nerves. And a sagittal sequence might look like this, where there's this disc herniation here causing some pressure on the spinal cord. Now this might be a typical situation in which you would consider doing an ACDF. So going in from the front, going to this disc, you can remove the disc itself, and as that animation showed, you can really remove the bulk of the disc. You would remove some of the bone spurs in the back here. That's one of the things that's unique about an ACDF, is you can really do a fair amount of bone work, removing all the stuff that's in front, not just the disc, but even the bone spurs that are pressing on the spinal cord. And you can see here that the spinal cord is well decompressed. The spinal nerve would typically be well decompressed. Once the disc is gone, we would use different types of spacers, and there are different types. Some of them are made out of bone, either your own bone, something that we call autograft, although that's very unusual. We don't do that often anymore. It could be made out of cadaver bone. That's a possibility that still remains quite popular for some surgeons. And then there's synthetic types of spacers that you can use, things that are either different types of polymers or plastic. Something called polyether ether ketone, or PEEK for short, was a very popular one for probably 10 or 15 years, and people still use them quite a bit. More contemporary, I think, spacers are often made out of metal. That's an option as well. I tend to prefer a 3D printed metal. It's printed out of titanium to look like bone ultrastructurally. So if you look at it under a microscope, it has kind of pores within it. It's so-called trabecular or porous, so that when you put that spacer in, it's kind of very inviting to bone, so bone tends to grow into it. But what spacer is used by your surgeon will depend a lot on their own personal preference and maybe somewhat on the clinical situation. Regardless of that, most of the time people will put a plate on the front of the spine, and the plate is secured with screws that tend to hold the plate together and to glue those levels together. So an ACDF is a procedure in which we do an anterior cervical discectomy, which is removing the disc itself, and fuse those levels together, which is gluing them together, and that's where the name comes from. So an ACDF stands for an anterior cervical discectomy and fusion. Some people will use the phrase as anterior cervical decompression and fusion, and those are generally interchangeable. This procedure, regardless, is generally performed with an interbody spacer, usually performed with an anterior plate, and the goal is to glue these bones together over time. And of course, getting the bones to fuse does take time. Now, if you go back to looking at that image from this section here and look at this disc herniation here, let's study a little bit more about what's done. So as I said in that before, you can remove the bulk of the disc material, remove the pressure on the front of the spinal cord on both of the nerves here. And if you do that, if you look at the other section, you can kind of see this is what it would look like. You could see here how we've removed some of the bone spurs, chamfered the stuff in the back here, removed some of the bone spurs here, some of the uncovertebral hypertrophy, we might call it. And we put in a spacer, and this is looking at the spacer kind of like a top-down view. The spacer occupies the space that that disc used to occupy. And you can see here that the spacers usually have a hole in the center, something we call a bone window. That gap is something that we'll often put graft material into. And there's different types of graft material, either cadaver-derived or your own bone or things like that, that you can kind of put in there to fill that gap and help facilitate the fusion or the gluing together of those bones over time. So you can imagine doing that procedure at a single level, but if you look at an image like this, here you can kind of see that you can also do a discectomy at 2 levels. This clinical scenario is a little different than the disc herniation situation I talked about before. Here you can see that there's some disc degeneration that's pretty pronounced at these 2 levels between C5-6 and C6-7. Because of the disc degeneration, there's been some height loss, so the discs are just not as tall anymore. There's some bone spurs here, and as a byproduct of that, this person has some kyphosis here. You can see that the spine kind of leans forward at that level. That is pathologic. That's not normal for the spine to have that alignment. When you go in and remove the discs at these 2 levels, in addition to taking the pressure off the spinal cord and the spinal nerves and removing the bone spurs, you can also open up that space so you can distract the disc space or restore disc height. And here's an example of what it might look like afterwards. You can see that there's a spacer here and a spacer there, a plate on the front, and there's very nice restoration of so-called lordosis, where this is a normal curvature to the spine, unlike this situation over here. So an ACDF, a very powerful technique for 1, 2, or sometimes 3 levels. One of the principal criticisms that an ACDF has is that because you are fusing levels together, it tends to cause degeneration at the other levels. So let's look at an illustration here that will give you a sense of a 2-level ACDF, in this case performed between C4 and 6. And you can see as there's range of motion here that there's some degeneration at the level above. There's stress on the levels above and below. And as people live their life after an ACDF, there can be some accumulation of stress at these levels adjacent to a fusion. That can cause degeneration at those adjacent levels, and we call that condition adjacent segment disease or adjacent segment degeneration. And it is one of the criticisms of an ACDF, is it is felt to be a byproduct of immobilizing some levels. So you're basically shifting the burden of wear and tear and daily use to the remaining levels, and those tend to wear out just a little bit faster. An analogy that I use is if you have, say, 6 discs here and you fuse 2 of them, it's like having 6 tires on your car and then removing 2 of them. And as you continue to put mileage on those remaining tires, they tend to wear out a little bit faster. So again, because you're shifting the burden to these remaining discs, people can tend to develop degeneration at these other levels, and we call that condition adjacent segment degeneration. So if we look in summary at an anterior cervical discectomy and fusion and think about the characteristics of it, we can really enumerate them in a structured way. First, let's talk about the decompression. An ACDF allows you to do a decompression from the front. You can decompress both sides, so it allows you to do a bilateral decompression, right and left nerves, right and left side of the spinal cord, or right in the middle of the spinal cord, but everything in front of it. So bilateral ventral pathology. You can remove bone spurs and disc material. So if people have a lot of bone spur material kind of pressing on the spinal cord or the spinal nerves, that can be removed. All the stuff in the front can be removed that way. It's very good for removing pathology that is at the level of the disc. But we can't necessarily get behind the vertebral body with this procedure. It is ideal for disc level pathology, whether it's bone spur or disc. The next thing to talk about, as I illustrated before, is that you can really restore disc height when you do an ACDF. Because you're going in from the front and removing whatever disc is there, and you have complete control over those vertebral bodies, you can distract them apart, open up the space, and apply an appropriate size spacer to restore height and thereby alignment at one or more levels. When you fuse a level, you are stopping it from moving, and although that can shift the burden to other levels, there are advantages to that. When you fuse a level, it allows you to decompress it very aggressively, as I mentioned before, but it also arrests the progression of degeneration at that level. Because it's no longer moving anymore at that level, and because you remove the disc in its entirety, you don't get another disc herniation, you don't have any further disc degeneration at that level, and you generally don't get more bone spur formation at that level because bone spur formation is felt to be a byproduct of motion, and degeneration is a function of use. Because that level is no longer moving, you don't really get any formation of bone spurs and other pathologies at that level anymore. So an ACDF allows you to arrest the progression of degeneration at the surgical level. There can be some degree of a loss of range of motion with the procedure, and it depends a little bit on every patient. When you take out a disc, you're usually doing it for pathology at that level. So generally that disc is not working that well to begin with. People may have already lost some degree of range of motion. When you do this procedure, you lose any remaining motion that they had at that level, you are losing. So there may be some local loss of range of motion with this procedure because it is a fusion procedure. When we fuse levels, the belief is that we are shifting the burden of continued use to the other levels that are still working, and an ACDF may contribute to adjacent segment degeneration or having problems at other levels that could potentially cause symptoms or even require surgery down the road. Overall, an ACDF is a very common, very popular, very successful, and incredibly powerful surgical technique for addressing pathologies of the cervical spine, particularly pathologies that are ventral to the spinal cord and the spinal nerves. The anterior cervical disc replacement is a very powerful surgical technique in the right patient. So let's start with an animation to kind of show what the procedure is all about. If you imagine this is the front of someone's neck, this is showing normal range of motion, and then kind of zoom in on the neck and see C4-5 and C5-6 degeneration is illustrated here. Usually disc replacements are great for soft disc herniation. So for example, here we have this disc here, but not a lot of bone spurring. And we remove the disc in this procedure and remove any herniations that are pressing on the nerves, again on one or both sides here. Now this once again creates a gap, and that gap is filled by a device, but this time a device that allows for preservation of motion. So we use a trial to select the right size implant, and this is just a generic looking disc replacement device that shows that you can kind of fill the gap there. It can be done at 1 or 2 levels generally, and what's so powerful about this technique is that these devices are designed to move. So you can see here with forward and back, flexion and extension motion, turning to the side, that these levels still move. So this is a motion preserving procedure, which is part of the reason that it's so powerful. So the disc replacement in general can be performed at 1 or 2 levels. That is the FDA labeling for it in the United States, and generally when I would use it is primarily for 1 or 2 levels. There are situations that are unusual in which you can use them. For example, you can do a hybrid procedure where you do a fusion at 1 level and a disc replacement at the other. Again, you can do more than 2 levels if you wanted, but the FDA labeling for it is really 1 or 2 levels, and that's the lion's share of the situations in which I use it. So now let's talk a little bit more about a specific example for when you might use it. Imagine looking at a slice of someone's spine like this, and you can see here that you would here's the spinal cord, here's the spinal nerve, here's a disc herniation pressing pretty hard on a nerve on one side. The bulk of the pathology here is really a soft disc herniation, right? Here you can kind of see that this is all soft. There's not a lot of bone spurs showing up here. When you look at a sagittal sequence like this, you can see here again, there's this disc herniation. It's causing some pressure on the spinal cord. On this particular section, you can't see the nerves, but of course it is also pressing on the spinal nerves, as you can see on the axial sequence there. So when we do this procedure, it is again done from the front. That's where the anterior part of anterior cervical disc replacement comes from. You go in from the front of the spine that's coming in here and remove the disc at this level. Now, as that is removed, you can kind of see that if you were to go in from the front and remove that disc, The one big difference between a cervical disc replacement and an anterior cervical decompression and fusion is that you do not remove any of the bone spurs that are in the back here. So you can see here how there's some bone spurs, those are the same bone spurs that were there before. When I do this procedure, when surgeons do this procedure, you're removing the bulk of the disc material. That includes the intervertebral disc that, for example, sits in the disc space, and also any of the soft disc material that's pressing on the spinal nerves or the spinal cord. You generally do not do a lot of bone work when you do this procedure. And the reason for it is because if you remove bone, you leave some bleeding bone. There tends to be a propensity for formation of reaction bone or reactive bone at those levels, and sometimes people can develop something called heterotopic ossification, which is the development of bone in places you don't necessarily want it to be. The most extreme cases of that will lead to a fusion, so sometimes people with a disc replacement device can actually go on to fuse that level, and that's kind of a more extreme situation for heterotopic ossification. So when I'm teaching this procedure, I generally tell people I don't do disc replacements in a situation where I expect to cause a lot of bleeding bone. So I might do that. So if I'm using a drill or using something called a kerrison rongeur, or affectionately something we call a punch, then I generally will not do a disc replacement. Those are situations that I would typically do a fusion. Now, if you were to imagine looking at the same implant, this case, and taking a slice through it, you could imagine that it might look a little bit like this. So here you can see that you've taken out the disc material. Here again is the spinal cord and the spinal nerves coming off on both sides. The disc is gone, but here you can see there's some bony structures, and those are native bony structures. This is something called the uncinate process. We don't generally remove that stuff. This is really a procedure in which soft tissue is removed. So to remind yourself again, this is the axial slice here. We've removed all this disc. We've removed this stuff over here. But there's some bony prominences that we're leaving in place. And the gap that is created by removal of that disc, that is occupied by this disc replacement device. And again, there's different types of disc replacement devices, but that's where it goes. You can decompress the nerves, decompress the spinal cord, and then replace it with a device like this, which is why we call it a disc replacement. Now, unlike a disc replacement, if you look at an anterior cervical decompression and fusion, or an ACDF, here you can see all this bone work can be done. You can remove the bone spurs here. Any stuff that's pressing on the spinal nerves you can remove. And the difference, you can remove some of the bone spurs in the back. Here's something we call chamfering of the osteophytes in the back there to really decompress the spinal nerves and spinal cord well. But when we do that, we usually fill it with something that is static. This device doesn't move. It's designed to kind of occupy that space, and it's rigid. It's a fixed structure. It's got like a static dimensions to it. And then when we put that in, we often put a plate on. This device often has some degree of pliability to it, and that's kind of a function of the engineering or the design of it. So this kind of gives you a sense of the different degrees of decompression that are done when you do a disc replacement versus an ACDF. Now, if you were to summarize the anterior cervical disc replacement and fusion, I think you could really summarize it in a few ways, but let's think about it in a structured way. First of all, with respect to the decompression, again, because you're doing a decompression from the front, it allows you to address pathology that is preferentially in the front of the spinal cord, ventral or anterior pathology. It does allow you, because it's a midline procedure, to get to both sides. So you can do a bilateral decompression when you do this procedure. You really are removing soft tissue, so it's disc and ligament. You generally don't remove a lot of bone material for the reasons that I mentioned before. So it's great in situations where the pathology is caused primarily by disc and ligament pathology, or primarily disc pathology. And that would be like classically a big soft disc herniation with radiculopathy. That's classic for it. It's really good for disc level pathology. You can't really get behind the vertebral body itself. And most pathology tends to be disc level, so that's okay, but it's important to kind of enumerate and just identify the fact that it's best for disc level pathology. This is a procedure that preserves motion. That's its cardinal strength. That's the situation in which we want to use it. That's probably its most distinguishing feature, is it preserves motion. It's a disc replacement procedure. It is not good for instability, and that might be a byproduct of the fact that it preserves motion, but if the motion's abnormal, we don't really know how these devices behave. So generally when people are candidates for this, I will check flexion and extension x-rays to see if they have instability, because these devices haven't really been studied for how they behave mechanically in the setting of instability, so I don't use it when people have instability. it does require some degree of disc height preservation. If people have a lot of disc height loss, I generally find it very hard to kind of distract it open and put one of these devices in. We consider kind of overstuffing the disc space by distracting it open and plugging it in. In my experience, these devices aren't designed for those kinds of axial loads, because you distract it open, put one of these in and kind of sandwich it in there, and then it kind of loads on it, and I find that people have very little motion at those levels. In general, what I think we've all learned in the spine surgery community is that you don't want to overstuff the disc space. You remove the disc and replace the space, and sometimes it's not necessarily as tall as you might get a disc space when you do an ACDF. So for that reason, I consider it a requirement that people have reasonable disc height preservation going into surgery, because you're not going to get any more disc height out of this procedure. There is a much lower rate of adjacent segment degeneration, and that's one of the strengths of this procedure. And it's felt to be because when you preserve motion at these levels, the other levels don't necessarily see that increase in stress. Some people would argue conversely that patients that are candidates for a disc replacement are different patients than people that are candidates for a fusion. So they're different populations, so it's kind of hard to compare apples and oranges. But in general, what the literature would support, now the most recent data suggests 10 years, that there is a lower rate of adjacent segment degeneration for a disc replacement. Many people interpret that to mean that if you're a good candidate for a disc replacement, you should really think about that as the procedure of choice. Lastly, I would say that in terms of the clinical situation, it has been primarily studied for cervical radiculopathy. How it behaves with respect to myelopathy, which was in the initial studies not part of the population that was studied, and how it behaves for neck pain is very hard to say. Not that a fusion is perfect for neck pain, but I think what's not clear is how disc replacements really help with neck pain. Having said all of that, in the right patient, which is generally a patient with a soft disc herniation, really severe radiculopathy, this is an incredibly powerful technique and something that I think is important to learn if you're a surgeon. The lion's share of anterior cervical procedures are really anterior cervical discectomy and fusions and anterior cervical disc replacements. But there is one procedure that I want to talk about which isn't quite as common, but is still very valuable and powerful. And that procedure is called the anterior cervical corpectomy and fusion. So let's take a step back again and look at some cervical pathology. Imagine a simple case like this where you can see that there's a disc herniation at this C5-6 level causing some pressure on the spinal cord. And you may have seen this image before. This is a very simple case of a single level disc herniation. Now, of course, discs can wear out at multiple levels, and you might have an image that looks like this, where you can see that there's some disc degeneration with some disc extrusion kind of pushing on the spinal cord at the C4-5 and also C5-6 and C6-7, and you can see there can be multi-level pathology. Now, when a disc spits out, it doesn't always spit out directly backwards. Sometimes, like at this 6-7 level, you can see it spits backwards and kind of down a little bit behind the C7 level. And so disc herniation sometimes can migrate a little bit. When people have a disc herniation that goes behind the vertebral body, we call that retrovertebral stenosis. So another example of that might be a picture that looks like this. And here you can see that there's some disc degeneration at the C4-5 and C5-6 level. C5-6 is pushing kind of straight back, but you can see here the C4-5 disc extrusion. You can see there's disc material pushing back a little bit behind 4 and really predominantly behind the vertebral body of C5. So that is called retrovertebral stenosis because it's behind the vertebral body of 5. Now, when people have disc herniations like that, it's very hard to get to from the front and take out with a discectomy. Because if you were to go in from here and try to take this out, you can see here how you could get some of this stuff back, but to get this stuff that's kind of sticking down and back and kind of downwards behind the body of 5, you maybe could get a nerve hook and a microscope and pull on it, but there's a little bit of jeopardy to the spinal cord, especially if the spinal cord is tight. Now, in situations like that, we generally favor a procedure called a corpectomy. And that is a procedure where you remove this block because it allows you to decompress this disc, get any of the disc material that's behind it, and really decompress the spinal cord very well. So after taking out that vertebral body and the disc, it may look something like this. Here you can see again C2, 3, 4, and you can see C5 is missing here. The disc between C4 and 5 and the disc between C5 and 6, what you could see over here, the 4, 5, and the 5, 6 levels, like those are gone. But so is the disc material that was pressing back here, and so the spinal cord looks very well decompressed between C4 and C6. All of the stuff that is ventral to the spinal cord has been removed. So that is called a corpectomy because you're removing the corpus or the body itself of C5. The vertebral body, it's full resection or most complete resection of the C5, in this case vertebral body. We call that a cervical corpectomy. And because it's done from the front, it's an anterior cervical corpectomy. Now, to fill this gap, you have to put something in it. And so that is how you achieve the fusion part of it. So here you can see, for example, you can fill it with a piece of bone. And in this case, you can see there's a gap between C4 and C6. Usually you'll kind of countersink it by kind of cutting a little bit into here and a little bit into here into those adjacent end plates. That leaves a little groove in the back here or something to kind of prevent the graft from spinning backwards into the spinal cord. That's traditionally how I do a corpectomy in terms of putting the graft. That graft material can either be your own bone, something that we call autograft, could be fibular or iliac crest, like in terms of where it comes from. That's quite rare. We will use that in situations where there's really a bad infection or maybe a bad tumor or radiation or kind of extenuating circumstances. Generally, taking a piece of your own bone that big can be pretty painful, and we don't generally do that if we can avoid it. You can also use cadaver bone. That's another thing that you can use there, and there's different types of cadaver bone that you can get that kind of you can use to fill this hole. Now, regardless of what you put in there, you generally will put a plate on the front, and the plate will have screws that go into, in this case, C4 and C6, but will go into the remaining levels adjacent to it to kind of hold those bones together, even to compress down a little bit on that spacer to hold everything in alignment until bone can grow into it from C4 into the graft and from C6 into the graft until it becomes one cohesive solid piece. Now, this is if you want to use a piece of bone, but there are other options. You can also use something called an interbody vertebral body replacement device, or some people call it an expandable cage. It can be made out of different materials. In this case, we're illustrating something made out of metal. In this case, probably titanium. That's a classic metal that we would use for it. And these devices go in kind of small and can be expanded. That's why we call them expandable cages. There's different mechanisms for them, but it allows you to kind of expand it to fill the space until this end plate or end cap, as some people call them, engages the adjacent bone. Now, what's kind of nice about these expandable cages is that you can kind of place them, make sure you like where they are, and expand them to fit them. So it tends to be a little bit easier to size and contour and make sure that it engages the bone well. It also, unlike the bone graft where you have to countersink them, you don't necessarily have to disrupt the end plate at all, because these end plates, end caps, typically have little pins that help kind of hold them and engage it. So it kind of sets a little bit. It's like got feet that kind of dig into the bone a little bit and prevent it from moving at all. So I have a lot less anxiety about this thing migrating or changing position because of that. Now, one of the nice things about not having to take off the end plate is by preserving bone on those adjacent levels, you don't have to worry so much about something called subsidence. When you have to cut out a little bit or countersink it, you remove kind of the hard part of the bone and seat it a little. You seat the bone or other thing on kind of softer bone that's underneath the end plate. You have to do that when you countersink it, and so that tends to cause a little bit of settling, or what we call subsidence, where the spacer can kind of piston into the adjacent bones. That can change the alignment. Now, having said that, I like expandable cages for that reason, but depending on the clinical circumstances, sometimes bone does make better sense. Regardless of whether you put a piece of bone or put some type of spacer, regardless of whether it's made out of metal or made out of a type of plastic or whatever it is, you still typically will put a plate on the front of it and typically put screws in to kind of hold those bones together. So that is how a cervical corpectomy is done. It is generally done to remove something that looks like this, where you have all of this retrovertebral stenosis, and then putting a much bigger spacer in to allow to kind of fill that gap that you've created with the plate on the front to get it to fuse. In summary, if you look at an anterior cervical corpectomy and fusion, we'll talk about some of the features of those. The decompression that it allows, again, because it's from the front, allows for removal of ventral pathology or anterior pathology. You can take the pressure off on right or left or both sides. It's excellent for removal of bone spurs, removal of discs. It's generally reserved for situations where the disc is behind the vertebral body. Those are the situations where corpectomy can be really powerful. Most of the time in my practice, I use it for removal of one vertebral body. Usually when you take out one vertebral body, you take out the disc above it and the disc below it, so it's typically 2 discs or 2 levels and 1 vertebral body. You can do more than that. You can do a corpectomy at one level and maybe a discectomy at the level above it. You can even do multiple level vertebral body resection, or something that's called a multi-level corpectomy. All of that is possible, although certainly much less common. When you do this procedure, it does require a fusion. That means you put the plate on, you're putting some type of graft material in there, and you're trying to get the bones to all glue together or fuse together. There is some controversy about whether a corpectomy is worse for alignment. And as I mentioned, when you put in a piece of bone, you often have to take off some of the adjacent end plates. That creates some risk of pistoning or subsidence. So I have found in those situations that you may not be able to get as good an alignment correction as with an ACDF. But with the advent of these expandable cages, I find that that's a little bit different, that you can get pretty good lordosis restoration and preserve it with less risk of subsidence. Having said that, the role of an anterior cervical corpectomy is for ventral decompression when a discectomy alone is not enough. It's a very powerful tool for degenerative conditions in which that's the case, but a clinical situation where I see it much more valuable is when people have tumors or sometimes traumatic or even infectious pathologies that can require the removal of a bone. It's a workhorse technique in those situations and a valuable thing to have in your skill set if you're a spine surgeon. In this chapter, we provided an overview of the different anterior cervical spine surgeries that we do. We started by talking about the exposure corridor itself for anterior surgery, and then we talked about some of the common indications for surgery from the front or from the anterior approach. Finally, we provided a summary of the characteristics of anterior surgery in general. We then switched gears and talked about 3 specific common cervical spine surgeries from the front. We started by talking about the most common procedure from the anterior approach, the anterior cervical discectomy and fusion. And we provided a description of that procedure with animation and illustrations, and switched gears to talk a little bit about a summary of the characteristics of that procedure. We then switched gears again and talked about the anterior cervical disc replacement, providing not only a description of the procedure, but also a summary of the characteristics for that technique. And then lastly, we talked about the anterior cervical corpectomy and fusion, which, although is not as common or popular as the other procedures, is still a very powerful tool and a useful tool in select patients. Next, we're going to talk about the same type of procedures, provide the same framework for posterior cervical approaches. We'll provide first an overview of the posterior cervical approach, and then talk again about 3 powerful surgical techniques that we use from the posterior approach. We'll talk first about the posterior cervical decompression and fusion, a very powerful technique for people with spinal cord and spinal nerve dysfunction. Then we'll talk about posterior cervical laminoplasty. And lastly, we'll talk about posterior cervical foraminotomy, a procedure that was very popular 30, 40 years ago and still is useful but not as popular today as it was back then. I hope you found this chapter useful and look forward to seeing you in chapters to come.